That's great. Thank you very much. I'm really pleased. I've presented in this room about 6 times, actually, I have to say. So I feel like I've kind of come home again. I'm really pleased to be here to talk to you about a subject that is quite close to my heart as a practicing ANP myself. I was asked to talk about advanced practice in the UK. It's quite a tough ask, and I'm going to whiz through some slides. I'm notorious for starting to veer off them, and by the end it'll be like we're having a chat in a pub to fix all the problems with advanced practice. So hopefully that will work for us all. What I thought I would look at first of all is what actually is advanced practice. It seems like a silly question, really, but this has been difficult for us to nail for a long time, both within nursing and in our allied professions as well. So I'll think a little bit about what it actually is, where it's come from, how did it evolve, was it planned or did it just emerge, did it evolve? Is advanced nursing practice particularly different? Does it add value that is different for our patients than advanced practice within other professions? And if so, how is that different? And in whose interests is it that nurses engage in advanced practice and that our paramedic colleagues, our physios, our SCPs and ACPs, who is it all about, and what is the evidence to demonstrate that and the way in which value is added? And I'll talk a little bit about where advanced nursing practice is headed in the UK and share with you the plans of the Royal College of Nursing for advanced nurse practitioners, and I hope that you will be interested to hear the direction we're going in. So what is it? I had kind of an interesting evolution in my own career. I've been really lucky. I've had some fantastic jobs, but on some of them, I did not really know what it is they wanted me to do. I knew what it was they were calling me, so I was a clinical nurse specialist. And the first time I got one of those jobs, I actually felt like I was just doing what any other relatively senior nurse in critical care was doing. I wasn't doing anything different. So I moved to a second job as a clinical nurse specialist and got the shock of my life, because all of a sudden, for the same pay, I managed half of the population of East London and had to put in their central lines and chest drains, and just wondered, how can this be? It's the same job title, it's the same pay point, how does this work? And then moved on to be an advanced nurse practitioner, and actually the organisation was a little limiting. They were very risk averse, so I was doing less than I had been as a clinical nurse specialist. So very frustrating, because you feel like your clinical capital is not being freed up in the interests of the patient population. And why is that? And I guess varying times during my career and working at the college, I've heard different views on advanced practice, and some people say, oh well, it's when you pick up more invasive or more interventional skills, or you become a prescriber, or it depends on what you're called. And actually that started to make me think firstly about what advanced practice is not, and particularly as opposed to what it is, counterintuitively. And what advanced practice is not is firstly a job title, because I think my own experience of having finished my MSc in advanced practice and becoming a prescriber and having learned how to do X, Y and Z and imaging competencies, at one point I was still called in my job title a clinical nurse specialist. So how does that work? And it's also about a level of practice. So this is really important, and this is where it comes into its own. And the Royal College, along with the national competency frameworks in the 4 UK countries, do not view advanced practice as a type or speciality of practice per se, but as a level of practice. It is the level at which you are practicing that makes you an advanced practitioner. And this has come back and forth through several iterations. And this document that I showed here was one of our first pieces of work on advanced nurse practitioners, and it moved on to a next iteration where it became a bit more sophisticated. There's a temptation to think that it's about how invasive you're being or how interventional you are, but actually people can be trained to do quite interventional things in a very protocolized or task-orientated way. So it's not really about the level of intervention or invasiveness. In fact, I would say now in my practice, having taken the terrifying step of moving pre-hospital into clinic-based in the community, which is terrifying, it actually is about knowing when to not be interventional, when not to prescribe, how to risk limit, and it is the level that you make those decisions at as a lead clinician that makes you an advanced practitioner, rather than the degree to which you are being interventional. It's also not a substitute for a medical role. I think now, particularly in Northern Ireland, they take a very commissioning-based approach. They will think about a service. Let's think about our cardiac surgery unit, our thoracic service, and how we are going to plan that from the outset, from square one, and how by including ANP roles or ACP or SCP roles can we maximise the capacity and throughput, but also the quality. So it starts from square one now, which I think is a very positive move. And advanced nursing practice is not the same as advanced practice in other within other professions, and the college are very clear on that. And so what is the nursing contribution? First of all, I've already said it's about a level of practice, a freedom to act, to commence and end episodes of care safely. For us, it can be a bit tricky. It does require the nurse, the individual, to balance their scope of practice with the limits of their competence. And I think that's why previously we've been quite risk averse. Does anyone remember the early journey towards prescribing? The nurses, they're going to kill them all. They're going to be overdoses left, right, and centre. That never happened. But it was, people were very, the risk aversion was very high, to the point where it almost made the pathways for the early prescribers quite arduous and detracted from some of the value they could have added in the patient journey. And my own prescribing placement was audited by someone popping their head in. There were issues with that. Those two regulatory concepts, scope of practice and limits of competence, are really important. They're important in general practice, in specialist practice, but particularly in advanced practice, because the scope of practice and limits of competence are different things. They are different regulatory concepts. And within a service, practicing at a very advanced level, matching those up can be difficult, and it is also quite individual when there is no national consistency in the framework, and that is something that the Royal College are trying to bring in this year in our centenary year, and I'll talk a bit about that in a moment. UK-wide, where are the Welsh? Any Welsh in the room? No? Northern Irish? Have I got a room full of English people? It's okay, like me. I'll be very proper, I promise. Most of you will be familiar with the National Competency Framework for Advanced Practice. On my previous slide, did you see how I glossed over one of the previously controversial points about the need to hold a Master's in Advanced Practice to be recognised as an advanced practitioner by the Royal College of Nursing? But actually, the reason that happens is not only because of the academic evidence, and there's very strong evidence that I'll give you examples of in a moment. It is already required in the Scottish framework, in the Advanced Practice Toolkit, in the Northern Irish framework. So all over the country, there was already an expectation that advanced practitioners are masters prepared. And I believe it's similar in the US, and certainly in the Republic of Ireland. To register as an ANP, you must also hold a master's. And that can lead to some issues, because people have developed their skills and moved to their career in different ways. But there are approaches to dealing with that. One of the toughest things has been getting the 4 countries to agree. And it won't come as a shock that the 4 countries can be quite competitive at times. I'm appalled, but I won't be a fair weather fan, but I'm pretty upset about the Irishman in that picture at the moment. What we have been able to do, though, is convene an advanced practice advisory group at the Royal College of Nursing, and they have agreed what our definition of advanced practice will be moving forward and how we will recognise and register those advanced nurse practitioners with the college. So this will be a new way in which the Royal College does its business, and one I think that will be very positive. The definition that's in front of you there, I think, takes the elements of all of the positive work that has been done before. It's very congruous with the International Council of Nurses, the Departments of Health, the 4 governments' definitions. But what it does is, apart from the miracle that every one of the 4 countries agreed, which was quite a relief, it does what previous definitions, I think, may have failed to do, which is define it. I think previously what people tried to do was explain it in its fullest, and that made it very long and quite unwieldy. And so this is the working definition that we'll be using when we start to credential, hopefully by the end of this year. And you'll hear about, I believe, how some of these concepts work in the USA. Towards the end of this session. Why are we doing it? In whose interest is it? I think there was a little bit of an odd feeling that this was a mono-professionally, it's just better jobs for the nurses are doing it in the interest of nursing. But in fact, it's really about unlocking the clinical capital of what is the largest workforce in healthcare in this country. And to not do that is an absolute disservice to our patients and to the public. It also, has anyone heard some discussions about 7-day care? Yeah, so have I. Lots of it. To realistically do that, if you look at the trainee numbers in our medical colleagues that actually go vacant, we are the solution to this in the Royal College of Nursing's view. Mobilising clinical decision makers from within the nursing profession is a realistic way to achieve that. And also, I know from working with my consultant colleagues that when our trainees move or rotate or move deanery or move organisation, advanced nursing practice gives clinical consistency in that service because we are there as our trainees progress and move on. And the next thing they will say to you is prove it. How do you know this? And we know it from decades of evidence and very strong evidence. There are randomised control trials that would make the peer reviewers at the New England Journal delighted with themselves. It's strong stuff. And the Office for European Cooperation and Development have shown in large multi-site studies that advanced nursing practice equals higher quality of care, quality of life, importantly, shorter stays, and increased patient satisfaction. Very interestingly, I didn't go for any US research. I didn't want to steal anyone's thunder, but our Canadian colleagues have also shown that it improves access to healthcare. And I think that is because we know how to navigate services and we know how to put people in touch with services that are closer to where they are. It's about mobilising clinical skill instead of having to mobilise the person themselves, which really adds value. And there are some great examples. I've put end of life here because I think end of life care, and if any of your patients, whether congenital or acquired or adult or child, if they're approaching the end of their life, having a clinical decision maker that can add value to their care by not having unnecessary steps or unnecessary movements is absolutely critical to those people being allowed to die well. And so it's a great example of where advanced nursing practice really comes into its own. But despite the evidence, we still have not secured the investment in advanced nursing practice that you would like to see, and certainly advanced nurse practice education. And why is that? So earlier I put up the NMC code as kind of a positive enabler, and now I'm going to put it up as a bit of a blocker. Because our regulatory code is the same for all 670,000 registrants in the country. And that makes it a little bit challenging, doesn't it, to know where you sit. More importantly, though, there's a public perception issue. And this lady, Libby Purvis, if I ever meet her, I shall have strong words. So she writes a lot about nursing, and this is one from the Daily Telegraph. And I suspect you can read the quote yourself. I can bring myself to read it without being a little bit enraged. But I'm sure if this lady needed to be, I don't know, propped up with some inotropes and have a bit of NIV, she would probably like me to do that before I mopped the floor. And I'm not saying that mopping the floor is not important. It is important, but it is about the way in which we deliver care now. It's technical. It requires the traditional legacy values, but also a high level of technical competence. And if anyone sees this lady, you can tell her I have taken up mopping, and I use the Daily Telegraph for just that task. But the public can also be the enablers. So this is all of the avoidable harm that happened in the NHS in England in 2014, and we always work a year back in our data. So look at what's going on. Look at what's harming our patients. So patient accidents. I think I'm going presbyopic if there are any. Okay, and so ongoing monitoring and review and escalation of care. Medication. In whose sphere of influence is this? If we are facilitated to fix it. This is pretty nursing-centric stuff to me, particularly the ongoing monitoring, the failure of handover between one care team and another. This is stuff where nurses really come into their own in terms of managing individual complex cases or diagnostic-related groups. And so I think we very much are the cornerstone of safety in healthcare and healthcare delivery. And if you combine some of the academic evidence that demonstrates better clinical outcomes and better quality of care with the fact that we are closest to those categories of avoidable harm, and so are best placed to prevent them if we are enabled to, that is a pretty compelling case to invest in us, is it not? It makes sense. But all of that inconsistency with job title and workforce plans makes it difficult. The public still don't understand it because we haven't managed to articulate it very, very clearly. If you add that into the context within which we practice, advanced nursing practice is very well able to manage diagnostic-related groups across the old boundaries of acute community. And in an NHS with 40% less beds than a decade ago, that is a pretty critical function. I think also the burden of risk that we manage is much more complicated. And so people need ongoing review and monitoring in a way that they may previously have not needed it. But their contact time with the inpatient bed base is much shorter. So who are the clinical decision makers who are going to take care of that? The RCN strongly believe that advanced nursing practice, and indeed advanced midwifery practice, will provide the solutions to this moving forward. So how will we do it? We're going to commence the credentialing of advanced nurse practitioners, we hope by the end of this year, subject to our council's approval. We will also continue to build the case with the NHS in each of the 4 countries that ANPs are the solution to delivering safe, responsive 7-day care. And whilst I work on the collegiate side of the house, you will also, I think, importantly need to know that we will seek fair conditions of employment and pay for the work that you do. So in summary, really, I just wanted to say that we are strongly invested in unlocking the clinical capital of the nursing workforce in the interests of our patients. This is about our patients. If you want to get in touch with the RCN at any point, if that scope of practice limits of competence issue becomes a problem in practice, it sometimes does, particularly when you move from one organisation to another, we are there for you and we can help you navigate that. But most importantly, in order to lever the public and for them to understand the value we add within our services, you need to be really loud about what you enable in your service. If you as an advanced practitioner or a specialist practitioner are the people who enable your service to tick, then you need to tell people that. So I promise, if you tweet me, you will get a retweet. That is guaranteed. That is a personal commitment. to retweet any of your great work. So thank you all very much for listening. I'm sure I've probably gone over my time, as is the Irish thing to do. But thanks very much.
Questions for the